Good evening, everyone. I want to welcome you to the Atlanta Suburban Alumni Chapter Mental Health Webinar, Mental Health Monday webinar. My name is Rashawn Jefferson. I am the chair of the Physical and Mental Health Committee for the Atlanta Suburban Alumni Chapter. Tonight's topic will be autism and anxiety. We have some lovely panelists here with us. We have Dr. Sadaka Cash and Dr. Joya Hampton Anderson. My co-chair, Cherie Hill, will be the moderator for this evening, and we welcome you to attend all our Mental Health Monday series that we host every Monday, the third Monday of every month.
All right, well, thank you for that welcome to my co-chair, Rashawn. I am so honored to welcome you all to our panel this Monday. We really want this to be a conversation. We have a Q&A box, so feel free to type your questions in the Q&A and we will get to them as best we can. We also are streaming on Facebook and YouTube, so feel free to drop questions there and we'll be moderating in all of those locations. Now I'd like to introduce our speakers. So Dr. Joya Hampton Anderson is a clinical psychologist and assistant professor in the Department of Psychiatry and Behavioral Sciences at Emory School of Medicine. Dr. Hampton Anderson received her undergraduate and master's degrees from Vanderbilt University and her doctorate in clinical psychology from Emory University. She completed her postdoctoral fellowship at Emory University School of Medicine. Her program of research aims to understand the sociocultural determinants of health disparities and integrated health outcomes in youth and families, with a particular interest in childhood adversity and chronic stress. She is interested in risk and protective factors that influence mental and physical health diagnosis, prognosis, and treatment, with a specific interest in culturally competent clinical practice and research. Clinically, Dr. Hampton Anderson works with youth and families using an empirically supported, collaborative, culturally responsive approach to treatment. She enjoys connecting with communities about her work via writing and talks, and she is also a member of our illustrious sorority. Next, I'd like to introduce Dr. Sadaka Cash. She is a licensed clinical psychologist from Cincinnati, Ohio. She became a member of Delta Sigma Theta Sorority Incorporated in 2013 through the Montgomery County, Ohio Alumni Chapter. She provides clinical care at Texas Children's Hospital in Houston, Texas, where she conducts diagnostic evaluations for children with concerns for autism and other developmental disabilities. She also engages in diversity, equity, and inclusion work through facilitating diversity trainings and other forums for improving care providers' cultural competence. Dr. Cash earned her bachelor's degree at Spelman College and a PhD in clinical psychology at Howard University. She is very passionate about social justice and its intersection with mental health and in the Black community, wellness and balance for Black professional millennials, and improving access into the mental health field. Welcome. So I'd love to, maybe hear a little bit from both of you. Why don't we start with you, Dr. Cash? Can you just give us an idea, what is autism?
So autism is a neurodevelopmental disorder, which means that it's brain-based. It looks, the criteria for autism is broken down into two kind of main categories. So one being social emotional reciprocity. So someone's social skills, how well they connect with others, their nonverbal communication, as well as their ability to develop and maintain relationships. And then the other bucket of criteria are more behavioral. So those might be restricted or atypical or unusual behaviors, body movements, types of play, atypical interests, where a child might be very, very interested in certain topics or certain objects beyond what you would expect for their age. And as well as sensory seeking behaviors, things like smelling objects, putting things in their mouths, and sensory sensitivities to things like light and sound. So we look to have like a constellation of symptoms in both of those areas in order for someone to fall under the spectrum of autism. As we maybe talk about different things to look for, you might notice that there might be a couple of things that you might find yourself doing or your child doing, but that doesn't mean that you or they have autism. But again, you need a certain combination of behaviors that would make someone that make that diagnosis appropriate.
Gotcha. Yeah, I think that's a good point too to mention, because I know even with my own little ones, when they were kind of around that 1-2-year-old age, you see certain behaviors and you're like, do I need to raise the alarm at this point?
Mm-hmm.
We're going to definitely get more into autism. I'd love to hear from Dr. Hampton Anderson just to set the stage. Can you tell us a little bit about what anxiety is? And then we'd love to have audience members ask your questions.
Absolutely. Hi, everyone. It's great to be here with you all today. Anxiety is the mind and body's reaction to threat. Okay, so it can be threat to life. It can be threat to something that you value. And anxiety is also marked by fear of uncertainty and uncontrollability. So our bodies react to anxiety in ways that resemble a lot of physiological distress and mental distress. Now, one thing I'll note is that we all have anxiety, and we actually need anxiety to survive, right? Anxiety keeps us alive. It keeps us motivated to do things. If a tiger were to run in your room right now, you'd get out. That's anxiety, right? The problem is today, sometimes our anxiety is really ramped up over kind of daily life stressors. You can get some of that same of the same physiological responses you would see. So one thing I'll talk about later is that we really want with anxiety to kind of stay in the optimal range most of the time. And the kind of stress management has to do with that kind of consistent modulation of your sense of anxiety.
Yeah, I love that you mentioned too, kind of dealing with the stress of the world. I can imagine right now with COVID and this pandemic not ending nearly as quickly as we thought. We may be seeing more manifestation of anxiety, in ourselves and, in our family members. And I can't wait to really get into this discussion. One of our first questions that we had here is kind of back to the basics with autism. What are some signs that a parent should look for?
So you spoke a little bit earlier about, when your own kids are around 1 or 2 years old, you're looking for certain things and wondering, if you should kind of raise alarms. Things that we want to be paying attention to are achieving milestones related to speech, motor skills. Oftentimes kids with autism have had some developmental delays in areas like speech and fine or gross motor. It doesn't mean that because you have a speech delay that you will have autism, but sometimes those things can co-occur. Things that come up come up the most often or that are the easiest for folks to pinpoint are things like eye contact. Does your baby track you and follow you? When you smile at your baby or your young child, do they smile back if you try to be silly or fun with them? Are they aversive to affection, not liking to be held? Do they have a limited interest in interactive play? Do you notice that they might just play, might come in a room where there's other people in play, but they don't really want to play with other kids, or they don't know how to initiate play? They might exhibit some intrusive social approach. So they might get too close or too in your face or too huggy or kissy or wanting to sit on folks' laps and not understand personal space and boundaries. With play, you could pay attention to things like the types of things that your child likes to play with. Do they make toys out of things that aren't intended to be toys? If they're playing with something like a toy car, are they just focusing on spinning the wheels, or do they actually like to drive the car? Are they lining the toys up and arranging them in certain ways and getting really upset if someone changes or moves those things? Things like echolalia, if you ask a question or say something, do they just repeat that part of your question or the last word that you said, and not in a way that's mocking or to be silly or funny, but almost parroting back before they respond to you? Adhering very strictly to routines and really needing things to be done and done a certain way, and not being able to tolerate changes in routine or schedules. And then some of those sensory seeking behaviors or sensory interests to things like loud sounds, beyond things that you would expect, like fireworks or things like that. The hand dryers in bathrooms are usually a big one for our kids, public toilets flushing. And then you might also see sensory seeking behaviors, like looking at things very closely or looking at people or things from the side of their eye instead of facing front. So those are some of those things. And again, you don't want to get too hung up on one or two of those behaviors, but if you're seeing social difficulties and some of those unusual behaviors, then it's good to have an evaluation done.
Okay, excellent. Speaking of evaluation, when is it appropriate to seek an evaluation? Is this something that your pediatrician will routinely do? And then I know you mentioned earlier that you do some DEI work. A lot of the members of this audience are, from the African American community, and at least anecdotally, I've heard that our children tend to be diagnosed a little bit later. So can you kind of touch on making that diagnosis for our children?
Yeah, so earlier on, your pediatrician is a great point of contact. They will, at certain intervals, be doing something called the MChat, which is a checklist of developmental milestones and things related to autism, those social play skills, emotional things as well. 18 months is, the earliest, around the earliest someone can be diagnosed with autism. We usually are we focus on early detection, so we can do early intervention, and wanting that detection usually to occur between 2 and 5. But sometimes that doesn't happen. Like the kids that I see are 5 and up. So I usually see school age kids. And so it's possible, anecdotally, I've heard stories about going to your pediatrician and telling them, I'm concerned about my child's speech. They're not speaking yet. And being told like, oh, just wait it out. They'll start to talk eventually, or my kids took a long time too. And so I would just, as parents, you have good intuition and know that like something's not quite right, and to push on that and to ask for referrals for things like early child intervention, or ECI is how it's referred to in Texas. So your child can get services like speech therapy, occupational therapy, even before they start preschool. So I think it's related to kind of diversity issues. And you bring up a great point about African-American kids being diagnosed later on. I think that you can attribute that to bias in the classroom as it relates to behaviors, or, certain behaviors being conceptualized as a child just being bad, or when it could be that they are overstimulated. The sensory things that are going on in the room are too much, or maybe they have a rigidity related to autism. And so changes are triggers. And so I think that does happen. And again, I think it's important to push and advocate with your pediatrician, with your school, because they can also do evaluation, that there are those concerns, and that to at least get it done. And if it isn't there, then we can kind of answer that question either way, but to have it done if there is some concern.
Excellent. Yeah, I love to hear that you have that working relationship and that partnership, and working with both the pediatricians and the school system to really make that diagnosis. I know, kind of looking at children, sometimes there's this concept of like stranger danger, and how do you know, maybe Dr. Hampton Anderson, you can address this, like, is that anxiety in your child versus do I need to be concerned about autism? What are some signs, that this is maybe an anxiety disorder?
Sure, absolutely. So in children, when we look for a change in kind of baseline functioning, when we're looking at the development of an anxiety disorder, and we want it to be kind of above and beyond what you would expect given their developmental period. So one hallmark characteristic of anxiety is avoidance or withdrawal, right? So that makes sense. If we're afraid of something, we want to run away. So we see that a lot in kids. Irritability, trouble sleeping, changes in appetite, whether that be over or under eating, are also really common symptoms of anxiety in youth. And then substance use. So I work with kids, teens, and young adults, and oftentimes there's a desire to kind of want to self-medicate because those symptoms are so distressing. Panic attacks are also clearly symptoms of anxiety. And then lastly, physical health concerns. So stomach pains, headaches, etc., that do not have an organic cause, right? So that they've gone to the doctor, we've ruled out any physical cause for symptoms, and then they typically come and see us. And one thing I'll note here is that youth of color are actually more likely to present with anxiety with physical health concerns first. And there are there are a lot of theories about kind of why that is. Some think it's because due to kind of stigma around mental health in communities of color, you're more likely to receive kind of validation and aid for physical health complaints as opposed to mental health concerns. Not quite sure, but that's really, really common to see kids present with physical concerns first before we get at what the anxiety is.
Well, that's great to know. I mean, for those, especially in the audience who may be parents, if your child is coming to you with physical concerns, that you do have to kind of obviously make sure that there's nothing, like you said, organic or medically, going on, but then really push the envelope and look into anxiety disorders. So thank you for mentioning that. We had a couple of questions in the chat that are tied to anxiety. So I'm going to segue. How can you help a child who probably is anxious and upset, but maybe they themselves aren't aware that it's anxiety?
Absolutely. So for parents, it's really important to kind of model what we call brave behaviors, right? So we don't want the parent to become anxious because the kids will then match that anxiety, right? So trying to keep your affect as calm as possible to serve as an example, because that is going to set the precedent for how the child then responds to different stimuli, right? So for example, if they're getting a shot or something, right, you want to model a brave face, because then they're going to want to be like mom and dad and be able to do that. Also listen and validate their feelings. We don't want to minimize kind of emotional concerns, right? Because that can lead to what we call internalization of different feelings, which actually makes anxiety worse. It's really important to kind of normalize that, like I started out with, like we all feel anxious sometimes. Anxiety is a normal part of life. It's how we manage it, right? And that goes a long way to helping reduce stigma and shame about what they might be experiencing. And then just show that you're there for them, right? Because you want to encourage them to continue to share and talk so that they're not keeping things inside.
Awesome. I think those are some great tools for parents on the call. And I know you obviously focus more on children, so maybe I can frame this question with regard to children, but I'm sure it could potentially apply to adults. You know,
Right.
when do you realize your anxiety has moved past a normal level? Like, when is it beyond that protective for fear level? And then are there certain like levels to anxiety? You know, when do you need to seek help from a psychologist as opposed to a physician?
Sure, absolutely. So, a lot of those symptoms I mentioned earlier about red flags for children also apply to adults. And I'll just highlight that term again, impairment in functioning. So, are you able to go to work, right? Are you able to fulfill your responsibilities, or are you feeling kind of paralyzed by the anxiety, right? And one thing I'll mention is that, like Dr. Hill mentioned before, stress, we all have stress, and recently we've all had a lot of stress, right, over the last couple of years. Consistent stress over time will lead to feelings of anxiety, right? So that's that modulation kind of I was talking about earlier. So if the stress is coming to the point where you're feeling like I can't do things, right? That is a mark of wanting to maybe seek additional help, whether that be therapy or talking to a physician about pharmacological approaches that might be appropriate, so that you're able to do your day-to-day life.
Excellent. Thank you. I'm going to kind of pivot a little bit back to autism. I know we were kind of initially at least focusing on making that diagnosis. We have some reproductive age women on the call, and a question that came up was whether or not there were any causes for autism that could be related to the mom's nutritional environment and stress level during pregnancy. I didn't mention earlier, but I myself am an OBGYN, and in some of my patients, if they've already had one affected child, this is definitely a question that comes up in my office.
Yeah, so the short answer is no, that we don't know what causes autism. We don't at this point believe that there are, things that a mom can do or not do to lead to autism. But you brought up a good point about if there's another child affected. So family history is a big indicator, and it's more it can be indicative of a higher risk for autism. If there's someone in the family with autism, if there are siblings with autism, it's more likely, if you have a child with autism, it's more likely that if you have another child, that child might have autism versus if you didn't have any other children with autism. So we know that there's a genetic component. And just like, with anything else, you want to, because autism is about kind of brain development, you want to do anything, all of those things that you would do or things that you would stay away from that might negatively impact your child, like using substances or, having high stress can negatively impact any child. So those similar things that you, Dr. Hill, might suggest for your moms that you see to kind of keep their a safe environment for their babies. Right now, we're talking a lot about vaccines, and there is myths about vaccines causing autism, and we don't believe that to be true at all. There was a study in the 90s about MMR causing autism, which has since been retracted because it was just a bad study with like 12 children who were specifically chosen for that study. It wasn't approved by an ethics committee. Like it just was not sound or safe or ethical research. And so after that, it kind of took a life of its own, and people, the kind of anti-vaccine movement around autism became really big and is still going. But we do not, the more rigorous studies have not shown any connection between those two things.
Thank you so much for highlighting the research on that topic. As I mentioned in my office, this also comes up quite often, especially now that we're kind of talking about COVID vaccination in pregnancy. The autism question comes up quite often. So thank you for that insight. Speaking of family history, I wanted to kind of tap into family history with anxiety. Can anxiety manifest in children as a result of very anxious parents or guardians?
Sure. So with many things in mental health, we talk about things being both nature and nurture, right? So typically there is some genetic predisposition towards anxiety, or kind of trait anxiety is what we call it. And then the environment can compound that, right? So the environment can then make what is genetically predisposed for someone come to light. And when we talk about environment, we're really talking about these chronic stressors that I mentioned earlier. So unpredictability in the environment, a lot of displaying of anxious behaviors by parents in the environment, and then adverse childhood experiences, childhood traumas, etc. So those things combined together are what kind of predict the development and onset of anxiety disorders in youth.
And do we ever see more anxiety in parents of autistic kids? I mean, is that a link as well?
I'm not sure that we see that, but it is, those disorders can be co-occurring, and it isn't unlikely that children, especially children or individuals with average to above average IQ or intelligence, can be at risk for developing anxiety around their social environment, right? If they're having lots of social difficulties, or they're having stereotyped or repetitive behaviors or movements, they might start to notice that other people are noticing those things, and maybe kids might say things or treat them differently, and may develop some anxiety around being around other people. So that happens, that is possible. And so sometimes it can be hard for folks to piece apart, because these disorders can overlap sometimes.
Gotcha. I had one additional question about kind of diagnosis when it comes to anxiety. Have we noticed a difference in anxiety symptoms in children during this pandemic? We had a prior session last year about virtual learning environment and social isolation, and didn't know if you had any commentary on that, Dr. Hampton Anderson.
Yes, absolutely. Clinically, we're seeing an increase in anxiety in youth, and the research actually supports that as well. And I'll add that for Black youth in particular, rates of anxiety have gone up over the last decade or so, more so than has been the case in previous decades. So recently, though, of course, we've been dealing with COVID, virtual school, a lot of transition, as well as a lot of socio-political unrest rate related to race-related stressors. So youth very young are grappling with these really big topics, and we definitely see that come out in the therapy space. I want to highlight that for kids that, what we've been going through over the last couple of years has been difficult for everyone, I think, but for youth with pre-existing anxiety disorders, right? Particularly when we think about things like OCD and things like that, the last couple of years have been doubly difficult, right, to manage. Now, as children kind of move out of virtual school back into school, there goes another transition, right? Because they've gotten adjusted, right? So there are a lot of things that come with moving with our new normal that we've been grappling with in the clinical setting for the kiddos.
Excellent. Well, I wanted to talk a little bit about autism again. We're doing a little back and forth. One of our one of our audience members has a nephew who is 2.5 years old. He's very social, doesn't speak, and he barely babbles. Are there good strategies to assist him? Is it too soon to place him on the spectrum?
So no, it's not too soon. I think related to speech, things that you want to do to help promote speech are to just expose him to as many words as possible, right? So have you or our mom or other family members to be constantly kind of narrating what you're doing, describing things, just like overloading on words, so that he can just increase his exposure, and to with the exposure to more words that he might then use more. I will also speak to my pediatrician about referrals for speech therapy, or talking to them about early childhood intervention, so that where you live, you should be eligible for speech therapy through the county that you live in. Before he starts school. So after he's school age, the school would be able to provide things like speech therapy or occupational therapy if they determined him eligible. But before that age, the county would be able to do that as well. And they do their own speech evaluation. And if they had concerns for autism, they might bring that up to the parent, who could then, I would, contact your nearest children's hospital to see what their wait list is like for an autism evaluation. These days, those are typically very long. So as early as you can get a child that you're concerned about on a wait list, the better. Where I am now, the wait list is like 18 months. So it's really bad. And so we're wanting to get kids identified as soon as possible. So if there are concerns, I would definitely seek that out.
Well, I just want to pause and once again say thank you to both of our panelists for the work that you all are doing, because clearly you guys are needed in this space. So thank you. One thing that I noticed you kind of mentioning, rightfully so, is parental involvement. So what are some techniques that can be used to encourage a parent who might be in denial about having their child screened for ASD?
So that isn't uncommon for that to happen. I think parents are usually more accepting or willing to seek help about things like, my child isn't speaking. They're not communicating. It's hard to communicate with them, or around their hyperactivity or inattention. So things related to more ADHD, which sometimes you might see some of those things in kids with autism. And so parents might note some of those things. And then I think it's for providers to be able to help kind of tease apart, like to get a really good developmental history and see what other things might be underlying that. To be able to kind of move forward and talk more about an evaluation. And then once families get to us, that we try to do our best about educating about what autism is, what it isn't, and how we can provide support around that and help the family to better understand and accept that. Sometimes when I give a diagnosis, families are not ready or welcoming of that. And sometimes they feel very relieved and happy that someone noticed that the thing that they're noticing that maybe a pediatrician or someone might say isn't a big deal. So I would maybe kind of focus on the things that parent is noticing. And then we can try to educate more and provide more support around why that might be happening, or other behaviors that are all linked together that maybe they're not associating.
Excellent. And speaking of symptoms, one of our attendees mentioned, hearing screening might be another thing that a person may offer.
Yes. Definitely
now, we talk a lot about children. Are there situations where maybe someone was like mild on the spectrum where they didn't get diagnosed in childhood? Maybe now they're an adult. Like, can an adult be evaluated for autism?
Yes. So, and especially prior to, more recently, when there's more awareness and about autism and people are talking about it more, the diagnostic definition and criteria has expanded as well. So the reason why we call it autism spectrum is because there are kind of varying ways that children present. or individuals present. And so, maybe 10, 15 years ago, it might not be uncommon 20 years ago that someone who is more mild or presenting in a mild way, that they maybe don't stand out as much, and kind of don't get flagged to look at those concerns more. And so as they become an adult, they might have more difficulties kind of socially, that may stand out. So an adult can absolutely be evaluated for autism. They would do some of the evaluation would look similar to how it does in children, in that there would be very in-depth developmental history that the provider would want to gather, want to do some cognitive or IQ assessment. And there are screeners that can be done, like the social communication questionnaire or the social responsiveness scale, and then more social or interactive observational measures like the ADOS, or the Autism Diagnostic Observation Schedule, which, in addition to some of those social, communicative, and atypical behaviors, we would be assessing for things like a person's insight into their future goals, independent living, money, relationships. Is there a certain level of rigidity that person has, and they have a lot of difficulty adjusting and doing things differently, or they're very concrete and have a hard time with figurative language or speech. I've definitely diagnosed a child with autism whose parent then, during that feedback appointment, says, like, the things that you're saying are things that you sound like you're talking about me. I kind of hear myself in this description. And this was a dad, and he asked, like, can I be assessed for autism? Should I? And I think that would depend on whether that person felt like the things that are more difficult for them socially are like we spoke about earlier, are they impairing, are they interfering with your functioning? Or do you feel like, at this point, I'm able to kind of manage and navigate well enough, and that I don't, need that diagnosis? But it can be helpful for additional services around, like, housing or vocational services, transportation, things like that. So.
Awesome. One thing I noticed that both you and Dr. Hampton Anderson mentioned was kind of impairment of functioning. So I know that this is something that may help a physician or psychologist kind of come up with a treatment plan. So kind of swinging back over to anxiety, what are the treatment options for anxiety disorders? Are there ways to, treat anxiety without medication?
Mm-hmm. Absolutely. So our first line treatment is cognitive behavioral therapy, right? So that's a therapeutic approach that asks you to kind of question your thoughts, analyze your behaviors, and see how they connect to your feelings, right? And oftentimes understanding that connection and sitting in the therapy space where someone is challenging anxious thoughts, and identifying kind of thoughts that might be a little distorted, they're driving anxiety, is really helpful for treatment of anxiety disorder. Sometimes medication is a helpful adjunctive treatment to therapy, and that can make it so that kids can better able to engage in the therapy space, right? So if anxiety is so high and there's that sense of being paralyzed, there's a lot of avoidance, right? That could make it hard for someone to engage in therapy. And if that's the case, and kind of complete task outside of therapy, right? So a huge part of CBT is kind of homework or at-home tasks, right? So medication could help them be able to more fully engage. There's also kind of as needed anxiety medication for kind of things like specific phobias and things like that, that are often prescribed to youth and adults when appropriate.
Excellent. Well, thank you for that insight and thorough review. Do you consider it necessary to get therapy if you have anxiety? Are there any lifestyle changes maybe that an individual could do if they're even hesitant to try to go to therapy? Like you kind of mentioned stigma earlier, particularly in the Black community.
Sure, absolutely. So for clinical levels of anxiety, particularly in youth and pre-adolescence, my professional recommendation would be to seek treatment, because we know that youth who are untreated for anxiety disorders around that age are at higher risk for developing depression in adolescence. So anxiety is kind of a gateway to some of our depressive disorders because of that withdrawal and avoidance. And if you think about it, if a kid has been withdrawing and avoiding for a while, right, that impacts social relationships, it impacts school, and then that's where we get kind of depressionogenic thinking and things like that. So definitely, if there's an impairment in function, we want to seek aid. And can you tell me your second question again?
Yes, just with the anxiety, are there lifestyle modifications that an individual could do because maybe they're reluctant to even try therapy?
Sure, absolutely. And that is where kind of our stress management falls in, right? Because stress is often that precursor to the development of the clinical levels of anxiety. So making sure you're sleeping and getting all your meals and engaging socially, right? Doing things that might feel scary, but are values and goals driven, doing those things anyway, even if you're feeling a little afraid. Those are all things that help manage stress, which we would then think would help reduce your risk of developing an anxiety disorder.
Excellent. I'm actually giving a talk on stress management to our residents on Wednesday.
Awesome.
So I love that strategy. So kind of pivoting back over to autism and talking about therapy, Dr. Cash, can you elaborate on the benefits of ABA therapy for children with autism? Maybe you can tell us what sort of therapy is available for autism.
Sure. So the ABA therapy, or applied behavioral analysis, is most helpful and useful, I think, for children with autism that have very severe behaviors. So maybe they get very aggressive when they're upset, and kind of have really big tantrums or outbursts. Those children might also have be what folks refer to as nonverbal. So maybe they don't have any words that they use, or many words to be able to express themselves. And so their behaviors are externalized. That's when I make a recommendation for ABA therapy. I will say that has become a controversial therapy. So it's been kind of one of our more hallmark recommendations. But as time has gone on, adults who have autism have reflected on their experience in ABA, some of them, and saying that they had negative experiences because it is a behavioral therapy, and it can be very systematic in that some might use ABA therapy to reduce certain behaviors that you don't want, things like, or certain that families might not want. So things like hand flapping or forcing a child to learn to make eye contact. And so some feel like it can be too forceful and like training a child to be a certain way. And so that's why I only recommend it for kids that have very, very significant behaviors where, again, those things are impairing, they're interfering with functioning. So it's not just that you're doing different things that make you stand out, but the things that you are doing are getting in the way of your learning, are getting in the way of you being able to function and be around your family and to be at school.
Got it. So that kind of segues nicely into this next question. Acutely in the moment as the parent, if you have your child who is maybe minimally verbal, if not completely nonverbal, and you're telling them no, potentially you're at a store or something like that, and then they literally fall on the floor. How do you handle those situations as a parent?
Yeah. And so those are times where, that can be very like embarrassing also. And the parents are experiencing lots of emotions too. Some things that providers recommend, even for kids that don't have autism, when a child is very ramped up, that you don't want to also yell and scream and go up with them, because then it becomes a battle of like who can get the most excited. And so you want to be as calm as possible to kind of get down on their level. It can be really helpful for kids with autism to use things like social stories, so we can can, show pictures about what the rules are in certain places or what they can expect in certain places. To use things like visual schedules, first we'll do this and then we can do that. Or kind of really helping the child in a picture-based way to understand what to expect from this environment, what we can do, what we can't do. And then to use things like, if your child is sensitive to sound, so let's make sure that we have our headphones with us when we go. Or if they have a sensory seeking kind of tactile, or they want to taste or put things in their mouths, and maybe they're grabbing things to do that at the store, to make sure that they have maybe like a necklace or something that they can use that is safe to put in their mouth instead, like something you can use as an alternative. You want to try to probably keep those trips brief, like let's be able to get in here, get the thing we need and get out. And so to really also try to kind of create a routine so that the child can expect and come to expect what's going to happen here, what I can do, what I can't do, and that it's not too new of an experience. I think grocery stores can be hard because they are very stimulating. Like there's a lot going on. There's people, there's things we see that we like. And so it can be hard to focus on, like, I can't just grab the thing that I want to grab. But I think it can be really helpful if you can create a good routine and schedule and like what to expect in places where there's going to be other people around and rules.
I love that in medicine, we always talk about, when we're called into an emergency, that first we need to check our own pulse, right? So that's something that's applicable, I think, to the parents and other situations in our lives here. So thank you. Kind of switching back over to anxiety, we talked about therapy. We talked a little bit about medication and when that might be necessary. Can you talk a little bit about like holistic medicine options? I don't know, are we using THC in kids, or whether or not that's a controversial treatment option?
It is, yes, and this comes up with my teenagers often in the therapy setting. So, we do not recommend self-medication with any substance for anxiety. Substances actually can increase mood concerns, increase the risk of mood concerns. But for THC in particular, we don't know about the long-term impact on youth brain development, which is kind of the crux of the issue. We know that those youth that engage in heavy marijuana use often show impairments in neurocognitive performance, impairments in brain functioning and neural development. So in a developing brain, right, that's pretty problematic, given we just don't have that long-term outcome data yet. And in some cases, THC can actually exacerbate, like I said, the risk of mood concerns, but also increase the risk of psychosis, which is very scary to see clinically. Sometimes that's a time-limited situation that happens where you might have psychotic-like symptoms after using, and sometimes it's not. Sometimes it is a precursor to the development of something like schizophrenia. So the risk is really quite high for kind of self-medication for anxiety, and the research is not there yet to make a kind of broad recommendation for marijuana use for anxiety management. And that applies for kind of all substances.
Okay, thank you. Yeah, I'm really glad that you mentioned kind of that unroofing of psychotic disorders. For those of you who are joining us from Facebook, if you go to our page, we did have a session during our last webinar series about, psychotic disorders and things. So it might be good to restream that. So speaking of CBD and THC, what is CBD oil use in autism? Is there any role there?
So we aren't recommending, similarly to what Dr. Hampton-Anderson described, we aren't recommending CBD oil or those kinds of supplements to treat autism. When parents ask about supplements or different diets or kind of alternative treatments, we don't have any evidence to suggest that like a gluten-free diet, for instance, is going to improve a child's autism. I think if there are alternative treatments that have a benefit, so maybe, you notice that it helps with your child's digestion, or a particular supplement helps to calm your child, then, if it's helpful in that way, then that's okay, I think. But we're not expecting those supplements to change a diagnosis or to take someone's autism away or cure things like that.
Got it. Thank you. Thank you for that. So speaking of children with autism, I know some children may also have a concurrent diagnosis of ADHD, and sometimes these ADHD behaviors can cause issues in school and functioning, and maybe really affect the child's trajectory for like career planning and things like that. Problems with executive functioning. What are some recommendations for support services in a child like that?
So for children in school that are having concerns or difficulties in the classroom, I would first be reaching out to school and requesting an evaluation, so that they can, and this can be around things like ADHD behavior, doesn't have to just be for autism, speech. And so your school is required to respond to your request for an evaluation, and depending on what they determine your child to be eligible for, so they can put them in a certain classification. If it's ADHD, that could be classified as an other health impairment, or autism is its own classification, or learning disabilities, things like that. And then, related to things like ADHD or problems with attention, then your teacher should be able to make different accommodations or modifications in the classroom. So maybe your child has preferential seating so that it's easier for them to focus instead of sitting, in the back of a room. Or maybe they're given breaks to move around, or to just take a break from their tasks so that they can focus. So doing things that can adjust or accommodate or modify the way that tasks are presented, what the expectations are for completion. Maybe you get additional time to complete tasks in a room that is distraction free. And so, each school will have its services and supports that it is capable of providing. But if you find yourself in a situation where your child's school is not able to provide or to help your child in the way that you feel like they need to, or they're saying they can't provide supports, then it's your school district's responsibility to find a placement for your child that can support them in the way that they need to. So I would first reach out to school to have an evaluation to see what they're able to do. And then just to continue to advocate for your child. You can get educational advocate if you need to, which are typically lawyers or someone who can help to represent you in meetings with school, to help advocate for things if you're getting, pushback about what they're able to do.
Oh, thank you. That was some very practical advice that we can definitely immediately put to use as needed. I had a little bit of a follow-up for some of the things that you mentioned. Does the child parent go through like a general pediatrician? Do they need to see a developmental pediatrician instead to help with some of these support services?
So with school, you can just go straight to the school, put it in writing that you are requesting an evaluation, so that they can come up with an IEP or an individual education plan or program, to be able to provide services and supports. So you can have an educational classification of something like autism or ADHD, but that is separate from a medical diagnosis. And so that you would want to see a specialized psychologist who can provide an evaluation about that. Some of our pediatricians and developmental pediatricians are becoming more comfortable and getting more training around being able to diagnose autism themselves. And so, but some aren't, and some will refer on to a psychologist. But, if you want to make sure that you are kind of covering both bases, so you can have your educational classification, which provides supports and services at school, but then you can also get an evaluation privately, which can help to inform the school and give them additional information for their own evaluation. But we want to keep in mind that those settings provide different, they're providing diagnoses, and kind of one doesn't impact or doesn't equate to having the diagnosis in the other space, if that makes sense.
Okay, gotcha. And then what's the difference between an IEP and like a 504 plan?
Yes. So an IEP will provide services, things like speech therapy, social skills group, while 504 is more just about accommodations or modifications. So you don't get any additional services with the 504. So someone might have a 504 for something around like ADHD. So maybe they just need accommodations and modifications in the classroom. They don't need additional services. But for things like learning disabilities or disorders, autism, very severe behaviors, we would want an IEP.
Gotcha. Okay. And then I know this has come up in some of my kind of friend groups, this notion that sometimes our children are labeled, right? And so if we go through the school and the school is kind of aware of this diagnosis, that can then hinder their standing in school, et cetera, talking about bias and things like that. Are there ways to get support outside of the school? What are your thoughts about that?
Yeah, so the private evaluation or getting a diagnosis through your developmental pediatrician or a psychologist does not have to impact school at all. School won't know about that unless you inform them. You share the report with them, or if we give forms to have teachers fill out, if you give the teacher the forms and tell them why they're being evaluated, they can know. But that's why the school evaluation itself can be important in that, if you're thinking about what your child's difficulties or challenges are, if those things are impacting their functioning in the classroom, it can be helpful that school is aware so that they can provide behavioral supports or social supports at school. And just thinking about how much time your child spends at school versus at home, that so much of what they learn about being social and their social skills and their socialization happens at school. So I usually try to encourage parents to share diagnoses with school. But I do understand and get that fear sometimes of the bias that could come, or the child being labeled and that coming with a negative connotation. But in some ways, that label can be very helpful for services and getting additional help and support in school. And then, depending on what the child's presentation is like, the teachers in school might already have some idea about, or they might have their own ideas about what's going on and who your child is and why they're doing those things. And maybe they aren't considering a disorder like autism. And so it could be helpful to show them like, hey, my child isn't just bad. They aren't just not listening to you, but they're having these challenges. And that can be helpful for other folks to know.
Thank you. One of our SOARs mentioned in the chat that it is helpful to have a medical professional or psychologist to help with kind of navigating this, filling out paperwork and that sort of thing. Kind of going back over toward the anxiety side, are there accommodations that can be made in school for kids with depression or anxiety? Is there an option for kids who are having anxiety related to, having mental health days in school? And is there a way to do that without being penalized?
Sure, absolutely. And I want to jump back to the end of Dr. Cash's point, which is so important. Psychologists can absolutely advocate for the school. A lot from our end, we often see the school, sometimes all the accommodations aren't being put in place. Maybe there is a concern about bias, and psychologists can definitely come and sit in on those IEP meetings, provide psychoeducation around some of these concerns that Dr. Cash has so nicely outlined, right? To keep everyone on the same page. And sometimes that needs to happen regularly. I think that's a great way to reduce bias. Regarding accommodations for anxiety and mood concerns, absolutely, that can come in the form of a 504 plan. And that will look different based on the child and the type of anxiety or mood concern that they have. Most often, it has to do with children kind of exhibiting a lot of distress in the classroom environment and then what to do, right? So for example, with anxiety, is marked by avoidance, right? So oftentimes kids want to leave the classroom, which we don't want to enable, right? Because we mentioned earlier, the more we avoid, that anxiety continues to go up. So we work with the school about maybe time limited removal from the classroom, right? And that is a 10 to 15 minute period where the child is then using skills they've learned in therapy, right? Or from the school counselor, and then re-entering the classroom environment. And then that behavior is reinforced, right? So learning that they can handle those really big emotions. Oftentimes, there a lot of praise and reinforcement is written into a lot of these 504 plans as well. And this is where the psychoeducation comes in, right? So if you're feeling paralyzed by anxiety, getting through the school day can be very difficult. So sometimes there are tangible or non-tangible reinforcers that we encourage teachers to use to encourage on task and brave behavior. So those are just a couple of ideas of things that can be written into a 504 plan, but often times kind of a meeting is drawn up, right, to look at specific accommodations for that child.
Got it. And then kind of looking at the big picture, I mean, dealing with anxiety disorders in children, which are the kind of the stepping block to the rest of your life. I mean, how detrimental can anxiety really be for a person's life?
Absolutely. And the answer to that gets at that avoidance piece. We call it anxious avoidance, right? The more avoidance that happens, particularly at a young age, the more that kids are not getting social skills, they're not doing well academically, they're not doing the developmentally normative things that kids do. And then that is what leads to depressive disorders and then related sequelae. So that's why, so avoidance is like the number one target for therapy and anxiety, particularly for little kids. This often comes up again around school refusal, right? So that is a slippery slope that can get out of hand really quickly at early ages, right? So if there's any anxiety around school, we want to get in and get that 504 plan done so that they're able to get reinforcement for whatever the hard thing is for them to do in the school environment. One particular therapeutic technique we use is what we call gradual exposure, right? So we are exposing the youth very slowly to the feared thing, right? And then providing praise and reinforcement as they achieve those things. So there are a lot of things that we do clinically to make it so that the impact of anxiety does not carry on throughout the life course.
Awesome. I love hearing that too. And so, it sounds like if you can work on the therapy as a young age, you can then help the child that will eventually, hopefully, become an adult and be functional and thrive. So I love that.
Mm-hmm.
Are there things that parents can do to help their child with anxiety become an independent versus a dependent adult? And then I'd love to pose that same question in the setting of autism.
Sure, absolutely. I think the number one recommendation for parents is not be really careful with the slippery slope of avoidance, right? So we don't want to enable any avoidance. We want to encourage gradual exposure to the feared thing and then provide reinforcement. And that is what begets more non-anxious behavior. That would probably be the number one recommendation. Oftentimes parents come in and they're afraid because the kid is so distressed, right? And they don't want to push them and make them kind of more upset. And that can actually just push us back further as far as kind of symptom severity. So that's why I encourage parents to come in, because we can come up with a gradual exposure plan that makes it so that there are things that the kid can do that feels manageable to them, and they work their way up to doing the feared thing or go to school or whatever it is, so that it's not as impairing over time. And parents play a huge role in that, in the type of work I do with children, youth, and young adults.
Well, I'm learning a lot. I'm a mom of 3, and we definitely have those moments where you're like, am I pushing them too hard? So I think you just gave me permission to push a little harder sometimes. So yeah, Dr. Cash, kind of same question except for autism. I know for me, I think a lot about autism kind of being a dependent position for a child once they get into adulthood. How can parents prepare their child for independent life? What does independent life look like for an adult with autism?
So I think that that can depend on a lot of different factors. One of those being, I spoke a little bit earlier about cognitive assessment or IQ, kind of what that person's intelligence or cognitive ability is like, related to their age level. Are they average or above average where they should be for their age, or do they have some cognitive delays or difficulties? That can impact someone's independence. Things we can do, in occupational therapy, you can work on improving adaptive skills. So being able to do things for yourself, like brush your teeth, take a shower, get dressed, make yourself a meal. As kids get older and closer to teenage years, we want to make sure that if they have an IEP, that there are transition goals put in place to help them prepare for adulthood, right? Do we have the skills that we need to be able to get a job? Or can we think about, if we're thinking about cognitive functioning, what types of jobs might that child or person be good at? And so we can work on things like independent living skills. We can work on social skills and social skills groups or social skills training. And including in that things about relationships, romantic relationships. If the child or adolescent is interested in romantic relationships, do they understand what the norms and rules are around how to have relationships in a healthy and safe way, how to pursue people, how to kind of function appropriately in that type of space? So occupational therapy can be helpful. Social skills training can be helpful, and making sure that school has those transition goals in place so that they're being prepared for life outside of school when that ends. So again, it can really all just depend on the child's cognitive functioning and level and where they are, and then how well they're able to, you want to start as early as possible. We talked about building those foundational skills to be able to prepare someone for adulthood, even if it were for something like anxiety. So we want to work on these things as early as possible, these self-care, adaptive skills, so that when they get older, they are prepared to be able to live by themselves and cook for themselves or do things. So we don't want to wait too late to try to make sure that those skills are there.
Excellent. Well, thank you. Switching back to Dr. Hampton Anderson, can untreated or undertreated anxiety in children then lead to depression?
Yeah, so we know that pre-adolescents, particularly around the 11 to 13 age range, untreated anxiety can lead to depressive disorders in adolescence and young adulthood. So when we think about clinical intervention, that's kind of like the prime time that we think about for that, because that's often where a lot of developmental milestones happen. And when kids miss out on those things, it can really put them behind socio-emotionally.
Awesome. Thank you for kind of clarifying that for us. So I had another question piggybacking on the notion of romantic relationships. This is a natural part of adolescent development. How can parents support their child who has anxiety with navigating this part of development?
Sure, absolutely. And what comes to mind first is social anxiety, a specific anxiety disorder. Oftentimes that can hinder kind of all social relationships, so regarding peers, but also romantic relationships. So I think the encouragement of developmentally normative behaviors, gently questioning anxious thoughts, right? So oftentimes with social anxiety, anxious thoughts might look like, oh, everyone's looking at me. No one likes likes me. It's marked by the fear of judgment in some way. And for teenagers, that's actually normal to think everyone is focused on you and the fear of judgment. But for social anxiety, like everything else is turned up just like a little bit more, right? To the point where it's paralyzing for them. And then there's that social avoidance, and that puts them behind. So I think encouragement of kind of developmentally normative social activities, putting them in the environment where they would meet peers and maybe potential romantic partners, and then questioning kind of any avoidance and underlying thoughts that go along with it.
And I know you mentioned teenagers, specifically with middle school students, and talking about avoidance,
Yes.
how do parents navigate, their child potentially not wanting to go to school because they're so anxious?
Yeah, absolutely. So I think kind of getting at the root of why they're going to school. And again, change in functioning. Is it all of the sudden that they're not wanting to go to school? Is it like last month school was okay and now it's not? And if so, we want to figure out why. Is it bullying? That's really common, right? A really common reason why kids want to avoid school. Maybe things are getting more difficult academically, right? And that is causing stress and therefore anxiety. And if so, why? Is a psychoeducational assessment warranted? For example, all of those things. I actually had a patient recently, I'll mention, here, there is a diagnosis that is medical in nature. It's called PANDAS, and it is kind of lingering kind of strep bacteria that leads to neurological functioning deficits that look like anxiety, right? So I'm seeing a patient now where school was okay a month ago, and then all of a sudden it wasn't. We got a medical workup and it turns out to be PANDAS. So we look, treatment for that looks the same, but that kid is also on a course of antibiotics. So I think how sudden the symptoms come on is really important, particularly when we're talking about a transitional period like the middle school timeframe.
Awesome. For the both of you, do you have suggestions for K through 12 educators who want to kind of maintain rather a calm environment, trying to keep something that's not overly stimulating, low triggering, especially, during COVID, where everything is kind of high tension?
Absolutely. That's a great question. And there's been so many great mindfulness movements in school that I love to read about. And I think that is a function of kind of us trying to reduce stigma around mental health in our society and understanding that a lot of mental health concerns and behavioral concerns in youth stem from anxiety and high stress, right? So I've worked with providers or teachers before that have implemented kind of daily mindfulness practices for youth. I think encouraging healthy stress management in the classroom is absolutely appropriate. I think listening and validating youth emotional experiences instead of jumping to kind of punitive measures are really, really important. And I recognize in the school environment, sometimes, people are taxed and that's difficult, but that can really go a long way towards having a youth feel heard and not kind of stuffing those feelings down. Because like we said, that makes anxiety worse. Right. Normalizing feelings and having them in the classroom environment. And again, these are societal issues I'm talking about now, right? So like societally, we all can do better about normalizing and accepting our feelings. Teachers can serve as a model of that for the youth that they work with. And then note that you're there for them, like I mentioned earlier, and then offer, if there is some trepidation around youth going to see a school counselor or talking to someone else, kind of offering to kind of go with them and be with that person, right? See that person and be with that person can go a long way, particularly with anxiety.
How about for autism?
Yeah, so I would say, environmentally for the classroom itself to try to make sure that it is, that it isn't overstimulating so that we can, as much as you can, to kind of reduce kind of unnecessarily loud noises or make sure that child work with the special education office to make sure that child can have access to things like headphones or fidgets, or things that they can replace to put in their mouths if they are, wanting to touch and mouth objects that they shouldn't. I think a good point was raised about, rushing to be punitive for behavior. So if we can do a functional behavior analysis and understand why certain behaviors are happening, what happens before a behavior and what are the consequences. So if we can understand why a child is behaving a certain way, then we can make adjustments the way we need to. When it is appropriate to for there to be consequences, that we want to make sure that those are consistent, so that the child understands that when I do this thing, this is the consequence, and that parents and teachers are on the same page about what those look like. So everybody's, the consequences are the same in across settings. So those would be two places that I would start with that. Also, things like socially, kind of pairing the child with a peer maybe that is typically developing or that has some really good social skills, and helping them to model so they can see certain skills modeled, or they can kind of have some good encouragement around initiating or trying certain things, or kind of helping them to get over to where the other kids are if they need a little bit of help with doing things like that. So I think those are some things that teachers and schools can do to be helpful.
Well, these are excellent strategies, and definitely empowering our educators on the call. So thank you both for taking that question. Following back up with the romantic relationships question, I know we talked a bit about it from the anxiety standpoint. What are some challenges that parents of autistic children may have when their autistic child wants to be in a relationship that's romantic in nature?
Yeah. So I think first that we don't want to assume that because a child has autism or some type of developmental disorder that they aren't interested in romantic relationships, or they don't have sexual desires or needs. We're talking about people, and so those things exist. And so it's about teaching this person, if they're not already understanding, when it's appropriate to do certain things. So we want to help to, I think, something important that's relevant here is that when it comes to social skills and norms, it's sometimes the case that kids or individuals with autism don't pick up on those things right away. So we have to help teach and support kids around picking up on social cues. So maybe you like someone and you told them you like them, or you're going up to them and they're not liking the advance. And so how can we help a child understand or pick up on someone's body cues or that type of information to let you know that someone isn't interested? Do we know what appropriate ways are to let someone know that you're interested? I spoke a little bit earlier about intrusive social approach, right? So maybe someone might just a child might go up to another kid and just touch them or kiss them or hug them, and teaching them that there are rules around that. We need to ask people first if that's what they want. So some of the things that we would be telling any kid about consent and, when certain things are appropriate versus when they aren't. But also just in things like social skills groups and training, working around what the rules and the appropriate rules and norms are around romantic relationships, and how to initiate those, how to maintain relationships, how to be flexible, because there's some likely an inherent rigidity that we want to do things a certain way, or have things go a certain way, and that when you're involved with someone else, they might also have things that they like. And so how can we be flexible and work on some of that rigidity as well?
Excellent. I mean, I think a lot of the concepts that you brought up are probably applicable even for non-autistic children, and consent and those sorts of things as we're getting into the dating world. So thank you for really breaking that down. One thing I really wanted to make sure that I addressed, this came up in the chat to the panelists, was whether or not there was a cure. I know we don't know really much about how autism is formed, or why certain people get it. Is there a cure once you have autism? Do you have it forever?
Yes. So with developmental disorders, we expect that they kind of stay with you, for lack of a better word, throughout your development. And so they may look different at different points. So a 5-year-old with autism might look different at 11 and different at 18 and 38 and on and on and on. And so we don't have a cure for autism, but what we do suggest is, again, that early identification, early intervention, and again, building those skills as early as soon as possible, so that as they get older, those things that are challenging, that they have good coping skills and strategies and resources around those difficulties. There can also be some follow-up over the years to see kind of what that progression looks like, so that treatment planning can we can adjust or modify our treatment planning around what those maybe more emerging difficulties are, or maybe we're seeing that certain behaviors have fallen off and we don't need intervention around those certain things anymore. So we can kind of follow up to see how the autism develops over time, and being able to adjust our recommendations based on those changes.
Excellent. And then my final question of the night, Dr. Hampton Anderson, is much the same. Is that the case with anxiety? Once you have it, do you have it forever? Is there a cure?
Sure. So one can be kind of genetically predisposed to having anxiety. So we talk about trait anxiety, meaning like that's just kind of how you are. Maybe you're just more of a high anxious person. You tend towards anxiety. And then we have the state anxiety, which is, in this particular situation, I get really anxious, right? One can learn to manage both very, very well. And those with trait anxiety, although you might always be predisposed to getting a little anxious, you can learn those skills that we've talked about to be able to manage that and keep your anxiety in that optimal level that we talked about earlier. So I think that is really great news. One other thing I would add, kind of going back to a couple of questions earlier, with kids and kind of learning to manage anxiety, a lot of it has to do with kind of, building confidence and building what we call mastery, right? So if school is really hard and anxiety provoking, is there an extracurricular that makes them feel really good about themselves and that they enjoy, right? That's a part of stress management and learning how to manage anxiety, but also build esteem, which is really, really important when we talk about, protecting against some of the depressive disorders that we talked about. So there are lots of ways to manage anxiety and live with anxiety in a way that's healthy.
Well, thank you, both of you. You definitely gave me some hope thinking about those that I know that are affected with both autism and anxiety disorders, and really did an amazing job of going through how we can make the diagnosis, how we can support parents, teachers, family members alike in getting to a diagnosis, resources are available, and really what we can do to optimally treat it. So I thank you so much for taking time out of your Monday to focus on mental health, and thank you for all of the work that you're doing with our youth. We are going to just pull up a couple of slides here to wrap up. Or at least I think we are. Maybe, oh, okay, there they are. I wanted to take a moment to mention, obviously, this is a recurrent webinar. So our next session on December 20th is on race, politics, and mental health. You can use the same registration link and QR code that you did for today, and join us to hear from Dr. Brown and then our own chapter member, Sharice Reyes. We have our survey, and just if you didn't get a chance to click on the link in the chat, please feel free to check out our QR code. Actually, the link is posted there, and we'd love to hear back from you. Any thank yous that you have for our panelists or information that you'd like to see in future mental health series, let us know. And with that, we will close out. Thank you again.
Thank you for having me.
Thank you, everyone. It was great.
Oh, there's the code.